convene, okay?
Okay, will I hear the recording? Did it start? Are we recording?
Yes, go ahead now, we are.
Okay, great. Good morning, everyone. Welcome. Thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. First, I'd like to propose a motion to adopt the minutes of the Finance Committee meeting held on October 8th, 2020. I will go through the members for their vote. Jose Pagan?
Yes.
Dr. Katz?
Yes.
Fenioski Peñamora?
Yes.
Barbara Lowe?
Yes.
And I vote yes, so the minutes are adopted. And in the essence of time, we're adjusting the agenda to consider the resolution first. I think Dr. Long is going to lead us through the presentation. After he and the team conclude, I'll call on each member individually for comments and questions. So Ted, why don't you go ahead and get us started?
Great, sounds good. Thanks for having me. So today we have a topic we want to bring up that's a twofold.
You read the resolution into the
Oh, yes. Okay. Authorizing New York City Health and Hospitals Corporation, the system, to sign 9-month requirements contracts with the following 8 firms, together the vendors. Rapid Reliable Testing, LLC, Rapid, Somos Healthcare Providers Incorporated, Somos Community Care Somos, BioReference Laboratories Incorporated, BRL, Fulgent Genetics, Fulgent, North Shore Medical Labs Incorporated, NSL, MedRight LLC, MedRight, Premier Assist Premier, Mako Medical Laboratories LLC, Mako, for COVID-19 testing services in schools, operated by the New York City Department of Education, DOE, and at mobile testing sites, with the system holding one 3-month option to extend each contract, and with the total cost of all 8 contracts over their full potential 1-year terms not to exceed $189,708,960. Okay. So we're going to walk through a presentation here for this topic. I'm going to set the stage and I'm going to turn to my Chief Operating Officer, Chris Keeley. This seeks to solve 2 problems for us. The first is to continue our school testing so that we can keep our schools open, reopen our schools and keep them open. By way of background for this, over the last couple of months, we've actually tested 160,000 plus students and staff members at our schools and found only about 0.25% have come back positive, making our schools a safe place, but we want to continue to have a rigorous testing plan moving forward for the schools that we reopen, and this is a critical piece of that. The second piece is one of the things that we've learned about in terms of how to fight the coronavirus is you have to have testing. That's your line of sight in the fight to identify cases, to identify contacts, to get them to isolate and quarantine. And we've learned that we have to bring testing to where people are. We've built brick and mortar sites, but we've learned that having mobile units that we can send around to where we're seeing upticks and to where testing is needed the most is a really critical piece of how we've been, I would argue, one of the most successful places in the country now of doing testing per capita on a per capita basis. So what we include here is a long-term plan that we've had for how we want to constitute our mobile testing fleet, and that is the future of testing for the Test and Trace Core program to fight against COVID for the duration of the crisis. With that, I'll pause, happy to answer any high-level questions. I'll turn to Chris to go into the details. Okay.
Okay, so good morning. My name again is Chris Keeley. So what we're looking at here is a two-part proposal. We have, as Ted said, the testing on the DOE side. This is in the public schools. Even since the document was written, the rules have changed, which speaks to the sort of very evolving nature. We don't know how much capacity we'll need at any given time. We don't know really what the rules will be a month or 2 from now when it comes to school testing, or really what the overall testing environment will look like. And so what we wanted to do was to go to market, identify some capacity, try to make them available to us, sort of pre-qualify them in a requirements contract sort of method, so that we would have available capacity should we need it on the DOE side or on the community testing side, as Ted said. So on the DOE side, the in-school testing side, the general practice has been that we've had somewhere in the neighborhood of 75 teams out on a given day. They've been out from BioReference, from Fulgent, and from Somos. Those are our current partners that we've been working with. On the mobile testing side, currently we have some work done with BioReference, and then we've had 14 mobile units of our own that we own and operate directly ourselves. What we're looking to do is be able to expand and make available more capacity on the school testing side. Now what we're looking at is, instead of testing in a generally monthly scenario in the schools, we're looking to test on a weekly scenario in the schools. The schools are going to be opening next week, pre-K, 3K, and grades 1 through 5 with weekly testing. That requires a considerable amount of testing capacity. So we'd be looking to leverage some of this available capacity for that testing in those schools. And then likewise, if the city's able to open up grades 6 and above, middle school and eventually high school, hopefully, it would be these same partners that we're contracting with here that we would be reaching out to first to try to have them assist us in these efforts. On the mobile testing unit, on the mobile testing side, we're looking to prioritize building out that capacity in a relatively short order as well. Under the scope of the contract, we have service level agreements around turnaround time. Looking at 48-hour turnaround time. If it's beyond 48 hours, we wouldn't pay for processing of those specimens. The DOE testing, we're looking at vendors who can provide approximately 20 teams. I'm expecting that's actually going to be more of a minimum. If we're looking to participate with some of these groups, it's probably going to be more in the range of 20, 30, 40 teams per vendor, so that we can have an individual partner cover more schools per day. Mobile units, we're looking at partners that can do at least 8 mobile units that they'd be able to deploy at least 5 days per week. The fee structure is either on a per test or a per team basis. On per test basis, it's typically $75. On the per team basis, it varies based on their team structure, but generally in the ballpark of a few $1,000s, something like $2,000 to $3,000 per team per day. What we want to be able to have, and this speaks to the criteria on the next page, what we want to be able to have is individuals, partners that have proven success in large scale testing, and that they can move quickly. That we're seeing here in the school testing environment, the rules got changed from monthly to weekly in pretty quick fashion. So we need to be able to bring in a new vendor if needed and have them move quickly. We need their teams to be able to scale up quickly, and particularly on the DOE side, one of the core requirements is their ability to handle data reporting. Because on the DOE side, what we need those teams to be able to do is send back those results to the DOE, to the Department of Education Situation Room. So Test and Trace and the DOE can work together to conduct investigations in the schools to understand, do we need to shut down a classroom for a day or two or more? Do we need to shut down a school for a day or two or more? So having vendor partners that can reliably process collect the specimen, have the specimen processed, and then reported back to us in the Situation Room in a timely manner, on the DOE side in particular, is very, very important. And the partners that we've identified here, we believe can do that. On the criteria, on the RFP, we looked at 25% for both cost and relevant experience, 15% for both ability to scale and data management, and 10% for community and language expertise and MWBE. The evaluation committee was involved folks from the operational side, from the finance side, from the clinical side, as we pulled this together. On the next slide, you'll see that the RFP went out in early November. We had a relatively expedited process here. We're only in early December now. From the time we published it to the time the proposals came in, I think it was around November 13th. The evaluation committee met the following week. We've met with the CRC before it went out and after it came back. And we've gotten 16 submissions. Based on the scoring criteria from the committee, we're choosing 8 of the top 9. We chose the top 8 originally after engaging one of them, saying that they would be likely awarded under the RFP. They revisited their own financial model they'd submitted and decided that it was no longer viable for them. So we went to the next one down the list. So we're choosing 8 of the top 9 on the vendors on that side. No MWBE firm submitted a proposal here. Through this expedited process, we're working with them very proactively to pull those plans together to make sure that they'll be able to put together clear MWBE plans in the days ahead so that we can work towards the target of 30% that we need to reach. Keith Talbian, who I believe might be on the line, he and I have met and spoken with each of the vendors already. There's a few of them that have very robust plans already coming together. The others are working them through. So we're happy to share details about that as they come together. 7 of the 8 vendors that we're choosing are able to do both DOE and community testing, and then one of them is only on the DOE side. The selected vendors there, Ted read out at the beginning and are also shown in the document. So with this, what we're looking to do, again, this is sort of a requirements contract arrangement. We're not looking for a minimum commitment. None of these vendors are guaranteed work under this. We go to them with no guaranteed minimum. That said, when we look to engage a partner, we are going to bring some minimum level of commitment. We're not going to look for 8 vendors each to do one small piece. We'd be more likely be looking for 1 or 2 or 3 vendors to do larger pieces. It's easier for us to manage, and it is more steady business from their side to make sure that we're getting the attention that the New York City school students on the testing side deserve and that the community residents deserve on the mobile testing side. The funding here is covered by Test and Trace MOU with the City of New York. And as I said, the MWBE utilization plans are being finalized with each vendor. This is a not to exceed of $189.7 million not to exceed on the contract here. So with that, we'd be happy to answer any questions.
Mhm.
I have a question.
Sorry.
Hello?
Sorry.
I have a question about around the,
Excuse me.
I'm just trying to catch up on, can you hear me?
Yeah, Barbara, let me go through and if you will.
All right, very well. Thank
Okay,
you.
thanks. One thing before we just start with the questions, it says on the summary request here that we're looking for 9 months not to exceed. I think the resolution says that it's 9 months with a 3-month extension. So is it?
That's correct.
That's correct.
That's correct. 9 months with an option to extend for 3 more.
Okay, so just the resolution is correct. The summary is a little
Yes.
not exactly right. Yeah. Okay. So great. So I wanted to clarify that. And the second point I did want to clarify is we appreciate that this was a very rapid process and it's very, very critical and important. And so thank you again for all the amazing work. And Ted, thanks for the context. But I want to just make clear that the MWBE utilization plans, you are pulling those together in time for our board approval next week, correct? That's going to be presented prior to taking it to the full board.
That's correct, Frida. You know, I can spend just a moment speaking to that. So typically, especially on, sensitive operational contracts, we have a few weeks to go back and forth with our vendors, especially 8. So some of these vendors have been in flight with their operations and have, clinical requirements on the supplier, on the staffing side. And we have PPE. So those are the real 2 areas of opportunity for subcontracting here. Some of the vendors are self-performing almost entirely, so with employees and not 1099s and not staffing agencies. So, that's a good and equitable business model that we don't want to disturb. One of the vendors is eligible for MWBE certification. They're going through that process now. Of the 7 that remain, 3 of them have already committed to 30% utilization, so that's great. One of them is looking like it's going to be around 10% because of that self-performance issue, so we're checking in on that. And then 3 of them are pending. We've asked for them to provide their responses by close of business Friday. We just had these conversations with them on Monday and Tuesday and Wednesday. So, it's a bit of a shift, and we're working very closely with them and SBS on finding minority firms or women-owned firms that are capable of providing the clinical staff that are necessary. That's a particular challenge right now because those clinical staff are in demand across the country because of COVID. So, we're trying to set utilization plans that are a reach and really a goal. And we're going to be working with them and have this as a monthly business review with each of them, so we can make sure we are all actively working on this issue.
Okay, why don't I anticipate there might be some questions here, so why don't I go through, thank you for that, Keith, but I'll pull the members now for questions. Jose Pagan?
So how much do we know about these firms in terms of their performance, reputation, whether it is with us or somebody else?
Sure. We've been going through and doing the reference checks for each of them, a number of them. As I said, we've been doing current work with 3 of them on the DOE side. They've all been adequate, if not superb, performers in some circumstances. There's one of the vendors has a longstanding relationship, well, longstanding by COVID standards, with the city of New York for COVID testing. And they've been a strong performer on that side. The others we're continuing to make sure that all the reference checks are adequate, but everything so far has been showing up as they're strong performers.
And Dr. Pagan, just to give you a data point there. So we've done 160,000 tests in schools, and that's working with some of these vendors that we're talking about here. To pull off 160,000 tests in schools, orchestrating all of that operationally was a heavy lift, but they pulled it off. The numbers speak for themselves.
And the next thing is just a quick comment. I mean, I just want to commend you and your team for all the work that you have been doing. I'm sure it's totally insane having to do all of this. And the fact that you were able to put this together within a month with all the requirements that we as a board, we look for and so on, it's very commendable. So thank you.
Thank you.
Sorry, Dr. Katz?
I would just echo what Jose has said. I mean, this has been a phenomenally challenging thing to try to do. And the circumstances keep changing. And the amount of testing that New York City is doing is unprecedented by any other locality. It has been exceedingly difficult to maintain this level of testing, but the group has done it, and I think they should be commended for it.
Thanks, Mitch.
Great, thank you. Sally?
Yeah. I'm sorry I had trouble getting in, and if these issues have been discussed, we can just keep going. But I have one, it is an extraordinary effort, so I applaud you all along with everyone else. I had 2 factual questions. You paid out approximately $235 million out of an anticipated $485 million of committed expenses. Have we reserved, or have we received, I should say, from the city, or will be imminently receiving the balance of that money for the expenses we've already incurred?
Hi, so just that particular slide that you're looking at, we have not yet covered. That's the update and the broader monthly finance update, and speaks to the overall test and trace program just through October.
Okay.
This work here is really, that only speaks to what has occurred through October. This is really looking forward and
Right.
is beyond the 485 mentioned there.
Yeah.
That only speaks to.
That just makes my concern greater.
Okay.
Because we already are committed to certain level of expenditures, haven't received them yet, and then we're looking at 189 million, which I know we're not legally obligated to spend, but politically there's just enormous pressure to have this testing done, even though it changes almost daily. So I'm just concerned. We have a challenged cash balance at the end of the year, and I'm just concerned about,
Sure.
Yeah.
So just, all of the tests, the entire test and trace program is covered by a memorandum of understanding with the
I
city
know.
of New York, which we had agreed to in the beginning.
Right.
And we work very, very closely with OMB to make sure that we, don't get ahead of them. They're certainly aware of this and have approved this not to exceed amount. And as in the slide that you have up now, again, we have paid approximately 235 million through October.
Mhm.
We have the 485 million represents expenses that we've already committed to incurred through
Yeah.
October.
Yes.
And then the city has to date provided us sufficient fund cash to cover those expenses, always, prior to our spending it. So there's been no impact on our cash flow, and they remain committed to doing so. So, and that is also covered by the MOU.
Yes.
So that just, while we share your concern, we've made sure to both include those risks as part of the MOU to protect ourselves, and also, again, work hand in hand with OMB. This is really their program, and as mentioned here, they're very carefully monitoring the funds that are available.
I know.
And
I
how we-
understand that. I think my concern still is we have whatever it is, $250 million of committed expenses, which we have not yet been reimbursed for. And so I would feel better if we were fully committed or fully reimbursed already. The MOU is only as good as its implementation. And if we had been fully reimbursed for the expenditures we've committed to already, I guess I would feel better. But I'm just concerned. I think this is a huge and sensitive undertaking. That's a comment. I don't expect.
Understood.
Understood.
Okay, thank you. Senioski?
Thank you, Frida. I wanted to ask a question, a couple of questions. The first one is that, I don't know if I heard correctly, but did you mention that if the test results are not provided within 48 hours, they will not get paid for that test, or I misheard that?
This is Chris, and Keith Talby and I are working through the contracts with the vendors now, but that's the intended service level agreement that for the lab processing portion of it, at least, they wouldn't be getting paid for any test beyond 48 hours. Keith, please feel free to add any clarification there.
Yep, that's correct. That's what we have in the contract.
Okay, so that means the $75 per in-school testing will not be paid if it's beyond 48 hours.
Correct.
Okay, that's good. I just want to also echo what it has been said. Thank you so much for the great work that you have done, and I can imagine how challenging it has been, but it's good that we have such a great team working on it, and I think all New Yorkers, and particularly our teachers and the kids in school really are the beneficiary, and we are very appreciative. I also wanted to ask questions, and I think Frida already kind of teed it up in terms of the MWBE. And Keith, your answers, if I understood it correctly, is like we are going to be working with them, but we are not going to get any type of commitments before the board meeting. Is that correct?
No, let me clarify. We are getting commitment. But we're asking, I think on day one, that commitment won't be there. So if you're looking at the invoice after the first week of services have been performed, it probably won't equal what the utilization plan is that they're committing to. So what we're doing is working with them to meet stretch goals that are going to require operational changes on each of these vendors' side in order to get to that utilization plan commitment goal, because the key piece really being the staffing availability is not there right now at this moment.
Okay, but in that case, some of these firms have already been working with us, and does that mean that throughout the process, again, we all did an emergency contract and all that require heroic kind of work from everybody. They did not have any NWB participation during that time, or that we can kind of look back of how their performance will be?
Sure. So I can speak to each of them. So let me start with BioReference. BioReference has been self-performing except for a very small piece of local clinical staff. They have not yet provided any NWB utilization, and we are asking them to. They estimate that their maximum availability for NWB utilization, anything that would be subcontracted, would be equal to 10%. Somos is a not-for-profit. We don't ordinarily place goals on not-for-profit organizations under the city's rules. Our policy, Penny, and it's obviously not formalized, but we are working on placing goals on not-for-profits where they make sense. I think they make sense here. Somos has a community of physician providers that are providing services. In conversation with them, almost all of those folks that are providing those services are minority owned. So we are going to work with them to get all those folks certified. And then we expect, a very large percentage of the Somos work to be subcontracted to diverse firms. Fulgent is the third vendor. Fulgent had not previously been doing this type of work. So they used a partner that they had previous experience with in staffing. They are not minority or women owned or certified. Let me actually take that back. They are checking to make sure they're not minority or woman owned. They are not certified. And so, Fulgent has used that partner before, and because of the operational difficulty of this program, it made sense for them to stand up the program from an operational perspective with a partner that they knew. So we're going to work with them to find alternative vendors for that staffing need, and on a week-by-week, month-by-month basis to move spend from their current staffing vendor to minority or women staffing vendor.
But the question is that, are we going to have a commitment? I understand that the numbers may be different. I can see that, and we can, discuss what the percentage will be, but are we going to get a written commitment and a plan for them to meet, or to the best of their abilities, the 30% by the time that we evaluate this at the board level?
They're all going to commit to a plan. I don't think they're all going to be 30%.
Okay, that's good. Well, I just wanted to encourage all of you to be as creative, and I know the constraint. I know, Ted, you are working really hard, and this is a very critical and important initiative that we need to meet. But I hope that all of you really put a lot of energy in encouraging these vendors to think outside the box and go out of the comfort zone to really look on how to improve their utilization.
Yeah, and Fenny, could I just add one more point there? I think if you look at the pool of contracts as a whole, we will exceed them.
Okay, that's more comforting. Thank you. Thank you, Frida.
Great, thank you. Barbara?
Hi, let me first commend everyone for the tremendous work being done. I can imagine how demanding this is, and now with another surge, it is pretty daunting. In the past, we've managed in New York to form a city-state coalition at every level to handle work such as infant mortality and other kinds of initiatives that affect our communities. Our work is significant, but there are 1.1 million children in the public school system. And so I guess I'm thinking that if you had your wish list, it might be to see how this is going to move forward if the demand increases in any kind of way, which I expect it might just increase to a significant level given what's occurring in our communities and in our environment. But thank you so much. I am really very pleased with the number of children who've come before us thus far and for the work ahead of us and as planned. But we're not in it alone.
Yeah, thank you, Ms. Sloan. Just to comment on that, we've been the first big city in the country to give our kids an opportunity to come for in-person education. So we have a lot to be proud of, and this will help us to continue that important work. Thank you.
Frida?
Yes,
Yeah, I'm sorry. I just have one follow-up question.
sure. Go ahead, Sally.
I don't mean to sound like a money Grinch, but I am. Of the $250 million of expenses that have been incurred but not yet paid, those were expenses incurred and not yet reimbursed by the 3 companies that were doing the T2 program for us. Is that right?
No, the 235 million that has been paid out and the full 485 million of committed expenses covers, again, only through the period of October,
Right.
and represents the full body of work under the Test and Trace core program. So it would include the testing that had been done through that point, which actually does not include this work because that preceded, except minimally, some at the DOE, I should say, because the schools had opened at that point. But it primarily includes the testing that precedes DOE testing. It includes the TRACE program, I'm sorry, and the isolation program, all 3, just to be clear.
Let me ask you a narrower question. Are the 3 vendors that are also going to be part of this new initiative, I would be interested in knowing how much of unpaid expenses have been incurred by those 3 firms. I'm concerned about a potential cash flow situation for them. But that's just my question. Very narrow question.
Okay.
Okay. That's it.
Okay. I don't have that specific, those specific numbers. We could get back to you on that. But we certainly would know, what we've committed to for those particular vendors. And yes, are mindful of cash flow for us as well as for them.
Okay. Thank you.
Sure.
Thanks, Sally. Just following up on that, Krista, I think this is going a little bit to the presentation, but just to address Sally's initial question on the 485 that's been of committed expenses in the past and the 235. Some of those it's sort of not just the word, we have funding for those dollars, right? It's not,
that's correct.
It's not that we're still negotiating funding with the city, et cetera. We have an account pursuant to the MOU where the funding is identified. We have sufficient funding in that account for those expenses.
That's correct. Yes.
Oh,
we work. Yeah. I mean, they're flowing us funds again prior to, there's always a lag between when, the services are provided, the invoices and the payments. And again, we work closely. They've already paid more than 235 million to us. That just represented the October update.
Okay. Thank you.
Okay, great. Any other questions from committee members? No, so I just want to echo all my colleagues' comments. Ted, the Corps is really doing an amazing job. Thank you. And I know how challenging it is, and moving forward will continue to be challenging. And just anecdotally, I've heard from many people about the great experiences they've had with our testing and the quick turnaround time. So I'm very pleased about that. And I think that the contract feature that Fenny pointed out on the 48-hour turnaround time requirement is good, just to keep that moving. So one additional question, just following up on Jose's question about the vendor's experience, because clearly we want to keep ensuring the quality of this. I know the 3 we've been working with have been doing a great job, and in unbelievable circumstances to have to deal with that. But of the new vendors, Chris, I know you said you're checking references, but have they all been doing COVID testing already in this context? And or what kinds of experience are we relying upon to evaluate their abilities?
Yeah,
both for the COVID testing and the mobile testing.
Yeah, they've all been doing COVID testing in different forms and fashions. As I said, 7 of the 8 are making themselves available on both the DOE and the mobile unit side, one of them just on the DOE side. But that doesn't mean we need to use all of them on both sides. That just means that they're available. Each of them has different strengths. And so I expect that of those 8, there's going to be a few that we would lean more heavily based on their experience, based on their reputations, more heavily on the mobile unit side. And likewise, there's a few that have been doing testing more intensively in the schools that we would lean on first. If we've got the 3 partners now, there's a natural number 4 and number 5 that we would go to in the next order of operations as we need to expand capacity, right? We would just sort of work our way down that list. But typical school experience might involve working with large numbers of school districts around New York State. A number of these are companies that have presence nationally, even a few of them internationally, that have been doing testing in school districts, large and small, none the size of New York City's, of course. But taken in aggregate, they're managing large volumes of in-school testing in a number of different environments, which I think is valuable experience before coming here.
Okay, great. Okay, thank you. So I think we will now go present this for a vote. I'm going to go through, I think Dr. Pagan had to leave. Dr. Katz also had to leave, but I believe Matt Siegler is on. Is that correct?
I am.
Great. Matt, I will poll you for your vote first.
Enthusiastic, yes.
Great. Sally?
A concerned yes.
Benioski?
I have a conditional yes that we are going to receive the plans for the MWB before the board. If we don't, I will vote no.
Okay. Barbara?
Yes.
And Frida, I vote yes. And I think the motion is then carried with Fenny's. Well, the motion is carried to bring it to the board at the moment.
Yes.
So,
Yes.
great. Thank you, team. Good luck.
Thank you, everybody. Good to see you.
Thank you.
I think next, John, we're going to have the financial update from you and the other members of the finance team.
Yes. Hello, good
Great.
morning. Thank you very much for your time, and we'll be respectful of it. We have 45 minutes left. We have a full deck here, but we'll make sure that we pace ourselves accordingly. I think there's good news here to report for the first quarter. We finished the year with a cash balance of $610 million. A net budget variance, we beat the budget by $128 million. Through the first quarter, that's pretty significant, and I think it was last year's performance in the last 2 quarters carrying forward here. Patient care receipts is very strong, $169 million, right? Greater than the same period last year. And as we reported, as we closed out at the last session, our year-to-year patient care revenue was $500 million over the prior year. That's very strong. Volume is down. I'll talk a little bit about that, right? We've been, since, the post-COVID period, it has been down, but it is coming back. On another slide here, I will step you through a little bit, some of the deeper analysis that we did there. But Medicare rates are up, and the VBP subcontracts, the stability of that constant flow of revenue is really, I think, providing a lot of, strength to us, through this COVID period. Despite it all, right, we keep focused on our strategic initiatives, and Krista and Matt will go through a little bit more detail there, but we've already generated $100 million, and we have what we call a line of sight. We can see down the road about $370 million. So generally, we're on target there. We're very disciplined about the approach and how we engage others. Senior management team. Everybody has an assignment to one of these different initiatives. But value-based payment is strong. Managed care contracting is doing very well, and revenue cycle continues to improve. We have a chart in here on staffing. I mean, we're featuring nurses in particular here. We had built the nurse model that's been fully built out. We actually have a little bit of a surplus of nurses, which is good as we enter the second surge. It was intentional not to reduce the nurses as we were looking forward here to the possibilities of a second surge. So this is the chart I mentioned. This is very interesting to us, us budget folks. You know, and we've never seen anything like this, you know, before. But on the left-hand side, we're showing you the volume. So volumes are down in outpatient by 11%. In the ED, also down 11%. Those are folks that treat and release. I'll talk a little bit about that. And in inpatient volume, down 18%. And you know, we're trying to understand the volume drops and understand what does it mean to the system. But on the outpatient side, you know, we are, you know, pressing to increase face-to-face visits. As we come back, we're encouraging the facilities to, you know, move away where appropriate from telemedicine, even though we think that that's something that we've built and we will rely on the second surge and even into the future. But the ED, you know, treat and release is interesting. We got more work to do here, but the folks that we think we're seeing not coming in to the ED are what we call 4s and 5s. Those are the less intensive people that probably in most cases would be better treated either in you know, at Express Care or even in one of our clinics. So more analysis to be done there. And on inpatient volume, Matt will talk about this. We've seen some, you know, strong results in our, you know, on-time surgery and surgical discharges. So we'll talk a little bit more there. But then you ask yourself, you know, how can we be down those percentages? And you look at on the right-hand side, revenue is actually up 28%. And you know, I want to thank my team. Right, they've done a lot of hard work here, you know, understanding these trends. But we know that there's enhanced COVID reimbursement, so that's about 8%. Revenue cycle, we have a pretty good line of sight there. It's just the hard work that Margie and her team are doing. And case mix is up significantly. I think it was 15% last year, another 15% this year. And then there's a Medicare rate bump and a timing, you know, payment in advance of a payment from Medicare. So this is interesting. And I think our next step here is just to test the resiliency of the revenue stream. Like, what does it look like, you know, into the future? And we can come back and report on that. But these trends are really, from, you know, us nerdy budget guys, you know, pretty interesting results. But this is why we're doing, you know, fairly well. And underlying all that, again, is the stability of, you know, the subcontract revenue. Questions here? I can move to the next slide. I think I'll turn this one over to Nina. Nina, do you quickly want to do this slide?
Sure. Hi, everyone. Can you hear me?
Yes.
Thanks. This is Nina Lara from the Corporate Budget and Fiscal Planning team. So we've been monitoring volume and revenue trends throughout the COVID-19 pandemic, looking at differences by service line and with attention to our Metro Plus and Health First risk pool members, as John mentioned. This slide also includes an updated estimate of the revenue loss due to decreased volume. So outpatient and emergency room treat and release visits dropped sharply during the spring COVID surge, and inpatient discharges dropped after the initial surge. All three service line volumes have increased over the summer and fall, and you can see that they are they're higher closer to September. Outpatient volume is now close to pre-COVID levels, though the revenue has not quite caught up, partially because of lower reimbursement for telemedicine visits. And I just wanted to point out that this excludes COVID community testing at our facilities and in the many pop-up sites and mobile testing units around the city. So this was just so that we could have a clearer comparison to the pre-COVID baseline for our outpatient services. The emergency room treat and release volume is still lower than the pre-COVID baseline, but those visits are slightly higher acuity compared to pre-COVID, as John mentioned, driving some increased reimbursement there. On the inpatient side, restarting elective surgeries has contributed to an increase in volume during the summer and fall compared to the post-surge dip, though volume is still below pre-COVID levels. The higher inpatient revenue during and after the surge reflects the higher severity of COVID patients and enhanced reimbursement mentioned on the previous slide. And the difference here is that we're showing it here based on the date of service rather than the date we receive the payments. We'll continue to monitor the service volume and revenue as the city experiences a new increase in COVID cases, and we'll be able to report back on this in the future. So I'll hand it back to John.
Yeah, the next slide here. This is pretty much unchanged from what we've shown before. This is just us monitoring the the risk and the opportunities. The state's finances, I think there's still their public numbers of $14.5 billion deficit. There's obviously risks associated with a second surge. 340B is one of the policies that the state is pursuing to carve out drugs and eliminate the 340B program. We saw a press release, I think yesterday, indicating that they were going to move forward with that proposal, but as they implement the cut, they're going to reserve $100 million for safety net providers, but they're not specific. So more for us to follow there. On the opportunities, side is delaying the dish cut, right? We'll always continue to advocate for that. And then the Metro Plus and Health First risk pools continue to throw off more money for the financial plan, and we analyze that very closely. James?
Thanks, Joe. So this is just to give a quick rundown of cash again, as we normally do. So as John mentioned earlier, we ended the first quarter with just over $600 million, $610 million at the end of September. As expected, we watched that dip slightly in October, closing with $450 million, which is a strong place for us, about 20 days. And November, just the beginning of this week, we estimate to be at about $400 million. We're obviously still closing out the month to see exactly where we stand. What helped us quite a bit this month was that we worked with the state to advance us just over $200 million of our dish payments that we generally receive in the January to March period up into November. As we requested, they were extremely helpful. We got those funds right before Thanksgiving, which allowed us to have that $400 million cash balance, 18 days, which is, again, right where we like to be, and kind of in a normal, stable, strong position. As we go into December, and as we're in December now, we're looking at likely dropping slightly to about $300 million by the end of the month. December is often sort of the weakest point of our year as we close out the calendar year. So this is not wholly unexpected, but obviously, we're very cognizant of it given the second surge and all of the things that we're working on. So to that end, we've been working with the state to see if there's funds that we can push forward, and additionally, the remaining $330 million that we generally receive in dish in the January to March period, we've already asked the state if we could get that as early in January as possible, and we'll continue to push on that. In addition, we are also looking to the federal government and to FEMA to help reimburse some of the costs that we had associated with the first surge. So as we've talked about, previously we received about $200 million to date from FEMA, but we have additional packages there, most notably for temp staffing, and we're hoping to try and push revenue along there. But there's been some delays and some challenges, but it's something that we're going to continue to work very aggressively on. So I'll pass it, John, back to you.
Okay. I think this next one, Meg.
Hi, everyone. So this slide is showing the membership growth in Metro Plus and Health First, Medicaid and Essential Plan lines of business through September. So as you'll see on the left side, Metro Plus's growth in Medicaid and EP is about 58,000 members, and Health First is 10,600 members. This growth is primarily due to increases in the state Medicaid eligibility and also the suspension on auto disenrollments for members that are timing out of coverage. And then on the right side, you will see our total risk pool revenue for all of our Medicaid and EP members, not just the new membership that's indicated on the left. And that's through the calendar year 20 quarter two. So through that period, Metro Plus and Health First Medicaid and EP risk pool revenues came in around $102 million. And due to the significant increases in membership, we're implementing several strategies to retain the growth. The first is we're gaining access to a state enrollment database so that we can do proactive outreach for members timing out of coverage. where we establish a facility level external referrals work group that finds opportunities for patient retention in our referrals and patient engagement. We continue to expand our express care and telehealth services. We're also working to ensure that our PCPs on file with the managed care organizations match where those patients are actually receiving care. We've also relaunched our MyChart steering committee, which increased the enrollment goal from 25% this year to 50% by the end of the year. We're actually up to 48% enrollment as of November 30th. And then finally, we're working to convert eligible patients from Medicaid into HIV, SNP, and HARP so that we can better address their needs and improve their care management.
Thanks, Meg. On the financial performance, Micheline, do you want to go through this? I think we've covered a lot of this already, but if you want to quickly go through it, I'd certainly
Yeah, I think there are two visuals here in the section, this one and another one that John has already gone through in the highlights, so they're more here for reference. So this is the $128 million net budget variance or margin that we ended at for the quarter. So we'll leave that here for your reference. We'll go to our staffing slide, which is our next one. Okay, so in here, what we're seeing here are two things. One, the quarterly view. So the quarter one view, which is the actual graph, the blue bars. And then at the bottom across is really where you see the full story. So this quarter one shows basically at this point that we are stable after our full investment in our core staffing model. Going forward, we're going to be focused more on our clinical services, our strategic initiatives, quality care enhancements, and patient care. You see across the growth from the start of fiscal 19, our investments that John spoke to earlier in nursing and nursing support, totaling about 830 full-time staff for nursing between the RNs and the nursing support. So again, reaching our core staffing investment there. And then you would also see in there our revenue cycle investment of staffing as well as the business plan. So we're basically focused primarily on achieving the strategic plans and initiatives that Matt will also speak to further later in the areas of OR growth, primary care, NYC care, and special populations and behavioral health. Yeah, and this is the second revenue view that's in there again for your reference more. So we could jump to the next one.
Hi, good morning. This is Krista Olson again. This here is a very high-level scorecard of our financial performance related to our strategic initiatives that we are managing throughout the system. A lot of this work has already been touched on in what you heard previously. It's integrated into both the efforts that have been spoken about as well as the performance that was mentioned in terms of certainly the revenue that we've been seeing coming in this past quarter. So just in terms of the high-level buckets that are here, we have 4 categories: growth and other service line improvements, revenue cycle and managed care initiatives, system efficiencies, and value-based payment initiatives. Just to speak quickly at what's underneath that a little, the growth and service line improvements includes some of the patient retention that was mentioned previously, really trying to encourage patients to stay within our system and reduce external referrals, as well as some of the business plans and other clinical service line efforts, and as well as improving throughput in our operating rooms. The revenue cycle and managed care initiatives includes a lot of accounts receivable work, coding and documentation improvement, coverage of the uninsured, and managed care initiatives includes negotiations with managed care companies as well as settlements. System efficiencies, just overall improvement where we can in terms of cost savings. And finally, value-based payment initiatives includes making sure that we're converting those patients that are eligible for higher tiers in terms of the managed care premiums like HARP and HIV SNP, as well as just overall, again, enrollment and patient retention goals and panel management. So you can see at a high level that we are we expect to exceed at the end of the year what our revenue target is. We actually manage internally to even higher targets, which may be partly why we're looking to potentially exceed what we have here. We also want to mitigate risks in what might come up in one area over another. So again, holding everyone to stretch goals. We do have a couple yellows, which we are showing in part because of just the current time that we're in. There are always risks associated with the timing of payments that we receive. And then, of course, the impact of COVID-19 on patient volume. We're carefully monitoring, but that would certainly impact where we end the year in some of these initiatives. So I'll pause for questions on this one, since we haven't gone through this before.
Frida, I do have a question.
Sure. Go. Well, we were going to do questions at the end, but
Okay, that's okay. That's okay. That's okay. Go ahead. Go ahead. I can go back.
And the second slide is actually related to this, so it makes sense for us to probably go through this anyway first. So we manage these efforts jointly with the growth team under Matt Ziegler very carefully because we're both interested in the financial impact, but also the operational and clinical impact on our patients. So I can turn it over to Matt to go through some of these KPIs that again are managed jointly by both teams to make sure that we're really succeeding in both areas.
Sure. I think several of these have been mentioned before, and I know folks are short of time. I'll just highlight a couple things that I think are particularly impressive and strategically important for us. We've talked a little bit about our operating room and surgical volume. This is going to wind up being the best year of surgical performance in Health and Hospitals history, which, if you think about it, is an absolutely astounding thing. Our operating rooms were largely shut down for all but emergency surgeries for several months of the year. But we as a system in this area and several others decided that the hard work of COVID was not something that we should kind of rest on our laurels about, but we should take that level of intensity and commitment and come out of it a lot stronger. And so as we opened our operating rooms again, we increased our on-time starts from 50, 60% to close to 90%. And we've brought back the volume to, and in some cases above, pre-COVID levels. So it's just one of these operational improvements that show the idea is not to just bounce back from COVID, but to bounce back and come out of it much stronger. So that's one I think we're particularly proud of and will build upon. And then the value-based payment initiatives and others. I think this is the story of this year will be that this is the year Health and Hospitals truly committed to and built the infrastructure to be a market-leading value-based payment organization. It's a lot of back-end work, it's detailed, it's operational, and it requires our teams on the ground to really understand that helping people be in the right health plan and manage their health well is part of our work. We're not just checking people in, we're helping them be enrolled and committing the system to the right financial model. So I think we're making great progress on all those things. As Krista said, we managed even more aggressive targets. So, my dashboards internally have a good amount more red on them. And we're talking to people every week at the facility level, all our senior executives, and really driving performance. But we're really proud of the team on that. And happy to take questions when the time is appropriate.
James, do you want to do FEMA?
Sure, John, I'll run through this quickly. So as we noted a little earlier, federal relief and FEMA front. So through October, we've paid out just over $1.2 billion. This is all still associated with the first surge. We expect that our total commitments associated with the first surge will be about $1.6 billion. So there's still some more funds to be paid out, but obviously we're getting closer there. As I noted, to date, we've received about $200 million from FEMA, which is the first advance that we had got it from our expedited work that we had submitted, way back in March. The second drawdown package for temporary staffing, which is our largest COVID expense, has been with FEMA, and we've requested expedited review and expedited payment. There is some delays and some challenges we're working through on their end, but we're hoping to continue to push that forward. We have additional packages being prepared for their review, as we can continue to keep moving things forward. On the CARES Act and the COVID federal relief funds, so as we've discussed previously, we've now received $1.2 billion, up from I think $1.1 billion at our last update, the largest of which from the provider relief fund distributions was for the hot zone or high impact funding to over $750 million. The safety net funding, we received $360 million. And then from the general allocation provider relief fund, almost $70 million. About a month ago now, the CARES Act opened up a third tranche of general allocation provider relief funds. We did submit our application, and we expect to get about $46 million from this pool. Hopefully in the coming weeks, we're waiting to hear since we submitted our application when those funds will flow, but that would obviously be welcome to receive some more funds. Despite all this, there's still probably about $50 billion of CARES Act funds that have not yet been distributed, and we're obviously continuing to push for those to be released as soon as possible, as well as hopefully a future relief bill as well. But with both the about $50 billion that remains and any new dollars, we believe that these funds should be focused towards high Medicaid and safety net hospitals, as well as state and local relief, as we mentioned earlier. The challenges that the state is facing on the Medicaid budget, and their state budget overall, as well as the city and the local governments. We believe that to stave off any cuts from us, those entities should be prioritized, and that's what we're continuing to advocate and push for.
Do you want me to go? I know we touched on this earlier. Do you want me to go through it again and more kind of higher level?
Why don't you go ahead, Krista, and just explain, just because we kind of did it piecemeal. So.
Okay, great. So this again represents an update on the full test and trace program through October. And that includes, as I said earlier, it includes the testing, but it also includes the tracing and the isolation program, which includes hotels. And again, through October, we have paid out approximately $235 million, but have committed to about $485 million through that point. The city has provided us with sufficient funding to cover those expenses as well as additional ones, since October. The city is carefully monitoring the funds available for test and trace as additional programming needs arise, such as the testing expenses, which we did speak about earlier, related to school surveillance, testing, and targeted responses in high priority zones. So far, no additional federal funds beyond the ELC grant and FEMA have been announced, which are our primary sources of federal funding for the program. So we, as James was saying, also anxiously await additional relief funds to support this work as well.
Okay, great. John, sorry, John, is that to conclude the? Okay,
Yes.
Great. So why don't I go ahead and see if folks have questions? I know there are some. Matt, do you have any questions for Dr. Katz of yourself?
So many, but that's my own problem. No, I'm good. Thank you.
Great, thanks. Sally?
First of all, it's staggering. It's just staggering the work that John and his team do under unbelievable and unanticipated circumstances. And so I applaud you guys and ladies for the terrific job you're doing. I had just one question, and it's on your FY21 cash projection. A little while ago, we talked about the whether Fred will sleep well tonight test. And that was, if he had $600 million of cash on hand, he slept well. I think he's not sleeping that well now. And I know at $300 million, you say it's a dip that's usually anticipated at year end, but projecting for the next quarter, how do you see the situation? I know a lot of the funds are funds you're awaiting or funds that you're hoping to get soon, but I'm just wondering what you're looking at the next quarter.
Yeah, no, I think it's a great question, and I'm sure Fred is sleeping very well at night. And it reminds us we should probably call Fred, right, and see how he's doing. But it's an excellent question, right? And I think for us, right, in this environment, I think it'd be any safety net, right, that's faced with the challenges that we have, right, to always be looking to make sure that we have enough cash on hand, right? And James does an excellent job of making sure that we're always looking forward. I mean, this is a big enterprise, right?
Yeah.
Any safety net has issues. This is a big tanker, right? And you got to look as far over the bow as you possibly can, even though you're in the fog a little bit. So we do that every day. I think it's part of the analysis we showed you with the volume and the revenue, right?
Mm-hmm.
That is very uncharacteristic, and we need
Yes.
to understand what's driving that trend.
Mm-hmm.
James will talk a little bit about our looking forward cash, but I think we're fine. I think what we focus a lot on is what's the backup plan if things are not going fine. And I think one good example is what we just executed on a couple of weeks ago. Is we called the state and said, we're in a lull, we'll be in a low period. It's typical for us. Advance us the 200 million.
Right.
We had conversations with them last week. We will do that again and making sure that they pay us January timely, and we'll look even further. When I had the old job, as the Medicaid CFO, I commonly did these sorts of cash maneuvers, right, to help, safety net hospitals, get further down the road. And we have a list of other things that we will, put in place, if we need to. But it's very important that we always have enough, cash on hand to fight the battle of COVID, and
Right.
reassure our clinicians that there will be enough there. But the further we look ahead, it's important for us to have that view.
Okay. Thank you very much. It's very comforting, John.
Yeah.
Thanks, Sally. Now James doesn't sleep well, right?
Yeah, no, it's James.
Exactly, but keep the Fred test. Right?
Great. Fenioski, questions?
Thank you, Frida. Again, I want to echo what was just said, and thank you, John, and everybody in your team for the great work. Definitely, you are magician, but the ones that make things reality, not just make believe. So thank you so much. Following up on Sally's question, if we go to that slide number 6 that we have right here, is it possible that maybe in future finance committee you can put like a trend graph on how much has been our cash in hand, like kind of pre-COVID? Because at least I don't have a sense on how good this is. Is this something that we have been very familiar with and we have all survived? Are we doing a lot better than in the past? At least I don't have a sense of what it means to end up with only 14 days. I think in my mind, I will think that that's very short time. I think we should have a lot more wiggle room, but maybe because if we look at the historical data, that's actually very good compared to our historical, but I don't have a sense. So
No, we have that chart when we will certainly make that available, by quarter. And I think it's informative, to talk in terms of days as another reference point. Of course, we'd like to be higher than 14 days, but we've been down obviously to this level before, and we commonly live with 14 days. But yeah, that chart is I think informative, and we can track against previous.
Okay, I'm based on you on this statement. How is 14 days? Is that kind of normal, or are we in the stress point with 14 days?
Yeah, we would like to, not go much further down than 14 days.
Okay.
We've been down below 14 days before. But I think the thing that's different here, right, is that we don't feel like we can also rely on the city. They have their own cash problems. And that's a big difference between where we are today, right, versus where we were in the past. And we're operating under the assumption that, we're more out here on our own. So.
And that's a good point because that was my concern. Where are going to be the lifesavers if we were to go a little bit below? The other question is on slide 13. Sorry, Frida, I'm trying to understand better this. If you want me to cut it short, I can cut it short.
No, please
Okay.
go ahead.
And slide 13, I just want to understand clearly the reference. Are we saying here that the FY21 actual is year to date, or are we having the projection for the whole year? I just want to understand what the graph shows.
This graph is for the quarter. So at the end of quarter one, we're comparing the quarter one period for this fiscal year against the same quarter one period for last fiscal year. So that's the first two bars. And then the next two bars is our actuals again for the first quarter against our budget for the first quarter. So we're showing you here the comparison of these two levels.
That's what I thought that's what I meant, but maybe we can put the quarter one somewhere in the slide because it's not clear that we are comparing quarter to year to date.
That's a good point. It is a good point. And I think maybe to add to that is that when we did the closeout for the prior year, we had the same chart in there too with the same kind of year-to-year reference point. So if you wanted us to provide that to you again, we could give you the full annual view, but based on last year's results.
I think that would be helpful, but I just wanted to be able, sometimes I like to be able to read graph by itself without anybody talking to me. And that's why I don't want to make wrong assumptions. Going now to page 15, if it is okay. I had a little bit of a challenge understanding the greens versus the yellow, because if I look, and again, I'm just going to tell you what I understand and you can tell me if I understood it incorrectly. The line of sight is what you forecast you will be able to accomplish for fiscal year 21, or this is only for quarter one fiscal year? I don't understand the target and the line of sight.
Sure. The line of sight is for the full year, where we, based on how we're currently doing, we would expect to end the year. The yellow is just meant to reflect a little bit more uncertainty in those particular areas that we're aware of, in large part due to the current COVID situation, where we're not in a normal year. So just taking the trend line may not be the right, may not be exactly where we end up. So just acknowledging a little bit of uncertainty in those areas.
Okay, so because the revenue target is what you have put for fiscal year, whole year, you're expecting, or you were targeting 85.5 million for growth and other service line improvement, but now you're forecasting based on whatever information you have right now that you may end up at the end of the year with 112.6 million. Is that the correct interpretation of this graph?
I think so, but if I'll phrase it and make sure that I'm understanding what you're saying. So if we take the like the revenue cycle and managed care initiatives, we have a target of $150 million for the year. This is really representing incremental growth in areas that we're focused on this year, really trying to emphasize. And we are, based on current trends, expecting to end the year in these particular areas at 218 million.
Okay, that's what I understand. Okay, that's what I understand. But I think, again, I like how you're using the colors to kind of reflect kind of risk and uncertainty on achieving your line of sight. Because if I look at the percentage of your target versus your line of sight, it's a little bit all over the place. Like for the first one, you are around 30% over, while in the green on the value-based payment initiative, you are only like 0.3% over. So what I'm trying to understand is that you believe that your line of sight projection, it is less risky to achieve than the system efficiency. Is that correct?
That's correct. I think based on our current performance with revenue cycle, it's really towards the target though as well. So, given how with revenue cycle, given how we're performing, and again, sort of what others were speaking to earlier, we are very, very confident that we're going to achieve at least that 150 million. But again, we're on track to receive the 218. The growth line is more contingent on volume and utilization, which is definitely likely to be impacted by the second surge. And so while again, our current trends show us hitting that 112, that extra level of uncertainty is what prompted the yellow.
So in that case, that color scheme is more talking about your confidence to meet your target. Is that correct? So
Yes, it's not a calculation. It's the
And there's other initiatives underneath it too,
Yes,
right?
that's right.
We're just showing you kind of how they bucket, but there's a whole series of initiatives
Right.
under.
Okay, I think that will be good. Now, if I understand it as a confidence level, I think that's very good, and I really appreciate you taking risk into consideration when I understanding that. Maybe perhaps for this one, since you kind of highlighted some initiative, and these are the end of the year target and line of sight, maybe if we can put a Q1 actuals versus what was the target for Q1, that will give us a really big kind of a reference point on how we are performing today. I think that's just a thought. And the other question that I have is on slide 18, if you don't mind. Again, it's just for my education. Sorry that I'm taking everybody's time, but it says that you have paid over 1.2 billion. And what it means is, and in the third bullet, we have received already 1.2 billion from those funds from allocated from COVID. Is that correct?
Yes, they're coincidentally the same number. We've paid out 1.2 billion, right, against the 1.6 billion in the entire COVID, effort. And coincidentally, we've also received $1.2 billion in CARES Act funds. Yes.
So in that case, financially, we're doing very well because we have more or less matched our revenue to our expenses in the COVID area.
At thus far, right? But I think we're also, as James had mentioned, we're waiting for the FEMA money, to be received, and that's what we're working on. So that will add more cash to cover the balance between the 1.2 and the 1.6. In essence.
Okay, that's good. Thank you so much, and thank you, Frida, for allowing me to ask all those questions. Thank you.
Yeah, Penny, I think it's great to ask the questions. I think the team has a good handle, and it's good for us to explore. One comment just on the chart before on the green and the yellow. I think this demonstrates sort of how, as John mentioned, there's a lot underneath each of these, and the team is doing well. They managed to a much higher target, so their line of sight can be better. But there are risks, and individual components within those are not necessarily as performing quite as well as they might hope or whatever. So I think it's good to sort of dig in on that, and I appreciate the questions. I want to move. Are you finished, Penny? Yeah. Okay. So Barbara.
Yes, I'm finished.
Great.
Yeah. Hello. Can you hear me?
Yes.
Okay. Well, I have one comment, and that's around maintaining the funding levels for nurses. It is one of the real important aspects of the work that we do, and sometimes, the budget can get pretty high given the nurse's salary. So I like to commend all efforts to keeping them involved. I just have one wish, but you don't have to answer. I would like to know what keeps you up at night, as financial projections may change with the surge.
What keeps us up at night?
Oh, what keeps us up at night? Oh, okay.
Yes.
Is that the question? What keeps us up? I try to sleep through the night, and I encourage everybody else to too, right? Because the days are busy. But I think, and again, if I explain, there's, we always need to make sure that we have, enough resources, and we're always looking to, our partners here to help us out. I mentioned a little bit, about the state, right? They've been a good partner. We have more work, to do with them. The federal government, right? We're always continuing to work with them. I think, they've been generous with us with the CARES Act funding, the 1.2 billion, but we think we should receive more. And then I also think, with our health plan partners, right? We're working with them. Matt and I are engaged in, settlement discussions on old claims. I think it's just a matter of us continuing to work all the possible opportunities that we have to make sure that we have the cash that we need on hand.
Wonderful. Thank you.
Thanks, Barbara. So I also just want to again thank the team. I echo everybody's comments here. I know you guys have been managing this very closely, and this very good picture, very unusual with volume down and revenues actually performing well. But I know that we can't rely upon that. The second surge is looming, as we talked about. This is very traditionally tight time of year for cash, and then all the uncertainties around that with what we're going through. So I know that I think, but I do want to point out that it is not purely, some of that disconnect in terms of the performance is due to timing and other kinds of one-time anomaly sort of events. But I think it also, I just want to make sure that it's recognized that it's a lot to do with what you guys are putting in place in terms of the initiatives that Matt and Krista talked about, and John, I know in the revenue cycle, what you're doing there. And so a lot of that is bearing fruit, and sort of hopefully we can, and I know you guys have looked at a lot of that, and we can do a little deeper dive on how that's performing and how that changes how are the changes we're making and how we do our business going forward is going to continue to put us into better footing. And the last comment, I just wanted to jump on them also because clearly you can see the committee's concerned about James's sleeping. Sally and Fenny pointed out, having some historical context, I think, is helpful. But obviously the circumstances are very different now. So it is, whatever I know what you guys are doing is really staying very on top of it and making sure you keep all your alternatives open. So thank you very much. I think you guys are doing a great job, so appreciate it.
Thank you.
So with that, I'll ask, is there any old business, new business? All right, no further discussion. This meeting is adjourned, and we are 3 minutes early.
Thank you, Frida.
Thank you, guys.
Bye-bye.
Be well. Stay safe. Happy holidays.
Yeah, same to you.